Presenting a rare case of genital tuberculosis. A 27-year-old lady with a primary infertility of 5 years and secondary amenorrhea of 2 years presented to us with 3 to 4 episodes of postcoital bleeding. On examination, we observed a 2 by 3 cm irregular friable mass which was seen at the external os and hanging over the posterior lip of the cervix and was bleeding on touch. The uterus was normal size at bimanual examination. Ultrasound confirmed the cervical mass, which had some vascularity, a normal size of uterus with an endometrial thickness of 5 mm. Most of the other causes of secondary amenorrhea were ruled out. We posted the patient for a hysteroscopy and a cervical mass biopsy, with the differentials in mind being cervical carcinoma, tuberculosis of the cervix, and granulomatous diseases of the genital system. This is the hysteroscopic picture. We began with the vaginoscopy technique, which is a no-touch technique in which the normal saline is the distension medium, and that itself helps in dilating, distending the vagina. Anterior lip of the cervix showed a stippling kind of vasculature. There was an irregular mass of around 2 by 2 centimeters at the posterior lip of the cervix. It had some amount of vasculature and seemed to be very friable, and the remaining part of the posterior lip of the cervix was smooth with a normal vasculature. We tried to negotiate a scope through this cervical mass to reach the cervical canal and the internal os. This was quite difficult, but the distension medium and the cervical mucus helped us achieve this. We always follow the simple principle of following the path of cervical mucus when the anatomy is distorted. A caseous calcific kind of lesion was seen in the cervical canal. Beyond this, we tried to negotiate the internal os. The internal os anatomy was quite distorted. We again used the simple principle of following the cervical mucus to negotiate a scope, and we were successful. The internal os was quite small and was difficult to negotiate. Caseous material was seen in one of the lateral walls. After negotiating the internal os with great difficulty, we found a completely distorted uterine cavity such that the walls of the cavity could not be defined very well. Also, the cavity was small in volume. The vasculature was quite irregular, as well as there was loss of endometrial gland definition in the endometrium, strongly suggesting an endometrial pathology. There were multiple hypovascular patches of endometrium. There is a very shaggy, moth-eaten kind of appearance of the endometrium. We can appreciate here the loss of gland definition of the endometrium. The complete gland definition is lost. We're trying to negotiate and go in and out of the cavity so that we can define the anatomy well. On one of the walls, we observed a caseous material floating in the distension medium, which superimposed our differential of tuberculosis. This strongly suggests a grade 3 intrauterine adhesions as per the hysteroscopy classification. We again tried to define the ostial area, but it was difficult as there was complete distortion of the uterine cavity. We found some more caseous material on one of the walls of the uterus. As we mentioned that these are intrauterine adhesions, probably due to an endometrial disease, most probable differential being tuberculosis. No attempt is made at releasing or treating this intrauterine adhesions unless a full AKT therapy has been taken. This patient definitely needs a histopathological diagnosis and then will definitely need a second look hysteroscopy to plan for her fertility. That is the panoramic view. Histopathology of a patient of the cervical mass and the endometrial biopsy both showed a presence of Langhans cells, foreign body giant cells, plasma cells and epithelioid cells, which was strongly suggestive of tuberculosis. AKT was started for her and a second look hysteroscopy is awaited. The organs affected in genital TB in the order of incidence include fallopian tube, endometrium, cervix, ovaries, vulva and the vagina. Genital TB mostly occurs by the hematogenous or lymphatic spread of Mycobacterium tuberculosis or a primary inoculation through semen. Most women are asymptomatic and have subfertility. MTB affecting the endometrium presents mostly with abnormal uterine bleeding in the reproductive age group, whereas it presents with vaginal discharge with or without pyometria in postmenopausal women. MTB affecting the cervix usually presents with a vaginal discharge, postcoital bleeding with or without infertility. The gold standard for diagnosis of genital TB is the presence of AFB, that is acid-fast bacilli, in the tissue smears or cultures and or tuberculous granulomas in histopathology examination. Hysteroscopy is a gold standard for the diagnosis of intrauterine adhesions secondary to MTB to check for the extent of distortion of the uterine cavity and the tubal ostia. It can be used as a prognostic tool for management and planning fertility, hysteroscopy guided endometrial biopsies and to take some cervical biopsies. Thank you.